I'm Dr. Fiona Lovely, and this is the Not Your Mother's Menopause podcast. I'm taking the taboos of menopause and perimenopause and bringing light to the dark. No bullshit, no shame. It's time for us to gain a new paradigm in female health, out with the old and in with the new, and I'm bringing fresh perspectives from someone in the arena. I've been practicing women's health for nearly 20 years, and I'm spilling the tea on what it means to live at midlife, knowing that the best is yet to come. I'm sharing my Gen X approach to living through this transition. Sassy, a bit sweary, and always honest. Tactical tips and instantly usable information is my aim. I hope to make you laugh and that you learn something new that helps you embrace the change. Together, we bring power to the peri. Onward to the podcast. Hello, listeners. Dr. Fiona Lovely here. This is the Not Your Mother's Menopause podcast. And you know, sometimes you meet somebody and you're like, oh, you're my people. Well, I recently had the pleasure of interviewing Dr. Tyna Moore for the show, and I am absolutely certain she is my people, which means she's likely your people too. So you may have heard the name Dr. Tyna Moore. She is out there talking about the GLP-1 medications and their health benefits. And she's been in several podcasts this year, and I feel so blessed to have had her on the show and had a chance to interview her this week. And this is a really contemporary conversation. The medications I'm talking about now are the Ozempic, Wegovy, Zepbound, Mounjaro, which are also known as semaglutide and tirzepatide, which we'll talk about using those names more likely in the show. And this is a really contemporary conversation because there are so many people that are taking these medications for diabetes, for weight loss, but it turns out they actually have some pretty extraordinary health benefits, and even at a low dose. So let me be clear. Controlling your blood sugar if you're diabetic, even if you're not diabetic, that's super important. And losing weight is if you carry extra weight, and I do, so this is something I'm really paying attention to. I have essentially all of my adult life, as did my parents, my grandmothers, etc. So I'm really paying attention to this conversation. And as I talk about in the show, a friend recently brought my attention to Dr. Tyna Moore. And as I was listening to some of the episodes that she has recorded, I made a list of the potential benefits to taking a GLP-1 agonist, like I've just mentioned, Ozempic or Mounjaro, and then Zepbound and Wegovy. And so I'm just going to read this list to you, which I do read in the episode as well, but just good to hear it more than once. Turns out these medications can be helpful for PCOS and infertility, for Parkinson's disease, Alzheimer's and dementia, and other neuroinflammatory processes. That one stopped me in my tracks, you guys. I'm telling you, I knew I needed to pay attention to that one. Helps with metabolic health, of course, obviously, non-alcoholic fatty liver disease, pain management, reduction of inflammation, helps with autoimmune, turning off those autoimmune genes. It helps addictions of all kinds, although the data is showing us for alcohol in particular, really helps control the cravings. But anecdotally, there are so many people that are just sharing like, okay, I started taking Ozempic for weight loss, and all of a sudden I wasn't online shopping anymore, or using my vape pen, and certainly reduces the food addiction and the food noise conversation too. GLP-1 agonists are also helpful in the health of heart muscle, reducing the risk of cardiovascular death, heart attacks, and strokes. So 1 in 2 women will die from a cardiovascular event. This is a real women's health conversation. And we even talked about, is there a problem with a deficiency of GLP-1, which is a peptide that our bodies make naturally? It helps control appetite and other things. And, is there a problem? Is there a real thing? Now, of course, we can't test for that, but Dr. Tyna talks about that. She said, there's a look to people that are GLP-1 deficient. She said, we can't test for it yet, but she said, that's my sense. And I found that just to be incredibly interesting. So this is the conversation you want to listen to about if you carry extra weight, if you've had stubborn weight most of your life, if you want a gentle conversation about what that means, what those extra pounds do to us. Again, this is two practitioners having a conversation. There is no judgment here. There is literally information dispensation so that you can advocate for yourself. Because the whole media machine makes this about a weight loss drug for skinny people and skinny celebrities. That's not what we're talking about. We're talking about really helpful, useful tools in the longevity and anti-aging toolkit for everybody. But also these medications is helpful for those of us that have metabolic challenges, for whatever reason that is. Genetics, lifestyle, behaviors, environment, toxins. I mean, there's just a number of things it could be. So I hope you enjoy this conversation as much as I enjoyed being a part of it. Let me introduce my guest, please. With nearly 30 years immersed in the medical field, Dr. Tyna Moore is an expert in holistic regenerative medicine and resilient metabolic health. She is a licensed naturopathic physician and chiropractor, drawing on knowledge from both traditional and alternative fields of science and medicine to provide a comprehensive perspective to individuals striving to enhance their health and well-being. Dr. Tyna holds degrees from National College of Natural Medicine and esteemed naturopathic medical school and the University of Western States Chiropractic College. Her work is not just about treating symptoms, it's about understanding and healing root causes to build robust foundation for long-term well-being. She is well known for her fierce and open-minded exploration of the peptides semaglutide and Ozempic as a longevity tool for healing. Dr. Tyna champions medical autonomy and individual accountability, and she's on a mission to help as many people as possible experience the freedom and joy that health brings. As the host of the Dr. Tyna Show podcast, a top-ranking podcast in the health and wellness space, and an international speaker, she is dedicated to empowering others to take control of their well-being, heal their metabolic health, and build strength and resilience. Her cornerstone recommendations for every patient and listener: weightlifting and sunshine. Additionally, she extends her expertise to support fellow doctors in cultivating their online practices, helping them transition away from the insurance-centric model to reclaim time, financial stability, and freedom. Dr. Tyna lives in Oregon with her husband and daughter and is a proud dog mama. I can't wait for you guys to listen to this episode, just packed full of information. Without further ado, here is my conversation with Dr. Tyna Moore. As a doctor, I believe that one of the best aging breakthroughs of the last decade is qualia senolytic, and here's why. As we age, our bodies tend to accumulate senescent cells. Senescent cells are also known as zombie cells because they linger in your body long after their useful function, wasting your energy and nutrition, which can contribute to less energy, slower workout recovery, joint discomfort, and basically feeling old. Qualia senolytic is a clinically tested formula with 9 vegan, non-GMO, gluten-free, plant-derived compounds that help your body naturally eliminate senescent cells, helping you feel years younger in just months. And the best part? You only take qualia senolytic just 2 days a month. It's an easy thing you can do to feel years younger, and it can literally transform how well you age. Go to qualialife.com/lovely to try Qualia Senolytic. It's backed by a 100-day money-back guarantee, and use promo code LOVELY, all caps, to get 15% off. As always, I'll leave the links in the show notes. That's Qualia Senolytic at qualialife.com/lovely with the code LOVELY to age amazingly well. This is the Not Your Mother's Menopause podcast. I'm Dr. Fiona Lovely, and I'm thrilled today to be joined by, or with, Dr. Tyna Moore, naturopathic doctor, chiropractor, and expert in holistic regenerative medicine. Dr. Tyna, welcome to the show.
Thank you. Thanks for having me. I'm excited.
Me too. So I have to tell you how you came on my radar. It
Okay.
was because as far as I'm concerned, you're everywhere right now. And is that because I'm looking for you, or is that actually what's happening?
I think that's what's happening.
It's
I've
cool.
just been on the podcast tour, so it's been fun. I've met so many cool people. That's probably the best part is I get to meet really cool people like you and make new friends. So
Thank you. Thank you. And I agree. I think the podcast for me has just opened up a whole world of fascinating people that I
yeah.
wouldn't normally be interacting with. So I totally understand what you're talking about. So I want to talk about a friend of mine briefly who is also a chiropractor who has psoriatic arthritis. And she sent me the episode with you on Mark Hyman's podcast, probably about 6 weeks ago. And she said, "Have you heard of this lady? And she's a chiro like us. And do you know about this?" And I was just at that time, someone had started to introduce the idea of a personalized dose of Ozempic, I would say tirzepatide or semaglutide, which, again, for the people listening, is either Ozempic or Mounjaro. You will have heard those terms. And my girlfriend said, "This is really something. Like, there's a conversation here that needs to happen." And I listened to the episode, and I've listened to quite a few episodes since then, which I don't always do with guests. I want things to be fresh. I want to ask you questions that maybe are just rolling off the top of my head instead of something else you've shared. And I heard you share so much of your own story in this conversation around the GLP-1 agonist class of medications. And I thought, this is the conversation of the moment. It literally is the contemporary conversation. So I want to say thank you to you for coming on the show. And let's have an open-minded conversation about how these peptides can actually be part of the longevity conversation. Please.
Yeah. Yeah. No, that's it. That's what it's all about. That was a tough interview because I was kind of getting barked at over the top by the other guest, who's a friend of mine actually, and I wasn't really able to say everything I wanted to say, and I have subsequently been able to say more of my piece on other podcasts, and I've done like gosh, 12 episodes on my own podcast on the topic, and so I've been able to get the word out, but for me, and I know that other great doctors have used a more personalized dosing strategy for GLP-1s in regards to weight loss and type 2 diabetes. The conversation I was trying to bring to the table that I'm very sure that I have pioneered is this idea, like, why aren't we using it for everything else? And why aren't we making this dose more inclusive to people, to tolerance? Like, why is it that we're only allowed to talk about the brand name versions that come standard? And oftentimes that standard starting dose, while it might be very appropriate for some, can be way, way, way too much for others. And as a naturopathic physician in Oregon, I have a full license to prescribe, and I've been doing so for decades. And I've always utilized compounding pharmacies or finding different versions of medication, even from the standard pharmacy, in doses that people could tolerate and that were more appropriate for them for the goals that we were looking to use, whether that was off label or on label, didn't matter. That's all legal. So that was the conversation I was trying to bring to the table there. And unfortunately, everybody keeps getting hung up on weight loss and type 2 diabetes. But as you well know, when people get to type 2 diabetes, they're often very far down a pathology. And I'm not saying it's their fault, but they're way down the line of metabolic compromise. And I was over here having the conversation of like, hey, there's a whole lot of us who are doing all the things right. And yet we've still got some struggles. And this peptide, also other peptides. There's other peptides that are amazing as well, which don't seem to be getting vilified whatsoever. I don't know why this one is. It wasn't really until the conversation around weight loss popped up that people started losing their minds. It's been, GLP-1s have been on the market for 20 years. But when I started trying to have the conversation around like, look at its impact on neuroinflammation, look at its effect on neuroregeneration, and as a brain expert, like we don't have any tools in that
None.
tool belt,
Mm-mm.
and it's got impacts on the cardiovascular system. It's got impacts on addiction cessation. We're now seeing the studies come out. So like a lot of data, fortunately, has come out in the past year since I've been talking about this to support what I've been trying to drive home. Parkinson's, Alzheimer's, I mean, things we don't have tools for. So diet and exercise, obviously, lifestyle interventions are always core. My entire platform for the past decade online has been all about metabolic health, strength training, eating steak. I've been telling people to eat steak and deadlift for way longer than it's been cool. And I'm glad people are catching on. And I'm glad people are figuring out that big pharma and big food are in bed together and that the diabetes industrial complex is a real thing and people are making a lot of money off of it. But I've been trying to just treat
Billions.
I've been trying to treat the people in front of me as they come in the door. It's not my job to judge their pain level. It's not if they're telling me the truth. It's not my job to judge whether or not they're telling me they're doing everything right and they still can't lose weight or they still can't get on top of X, Y, and Z. And then for me, I was hitting menopause and my autoimmune disease coupled with the stress of pushing back against the narrative for the past several years. I pushed back hard is for the past 5 years and I paid greatly for it. And so for me, it was like, this perfect storm of factors and my immune system just went belly up on me and every tool I had and I have every tool available, every tool I had available was not working, including all the other peptides. So that's when I pulled out the GLP-1 and decided to give it a try and started talking about it. And really, I think it's changed. I will give myself credit. I think it's changed the entire landscape. So the fact that you heard about it, I promise you that was the conversation I started, and I took a lot of heat for it. I took as much heat for that as I did for pushing back against the thing of 2020. So
Mm-hmm.
if that tells you anything, that
Mm-hmm.
there's something going on. And so, I mean, the whole functional medicine community turned on me. I have enemies up the wazoo now because I'm the GLP-1 pusher, right? I have no tie to big pharma whatsoever. I'm not even talking about big pharma. I'm talking about compounded, substances over here. And anyway, here we are. So
Well, it's so often the case. It's like, oh, people are paying attention over here, but the real conversation is over here. Like that's so, you look at the media around the GLP-1 agonists, medications. And for the listeners, again, when I'm talking about that, I'm talking about the trade names Ozempic and Mounjaro, Wegovy, Zepbound. Have I missed any of them? Those are the
that's
big
pretty
ones.
much it.
That's
Yeah.
it. Okay. And so that's either semaglutide or tirzepatide. And what Dr. Tyna is saying is these are peptides. So we'll refer to them with all of those different options in there. But if you look at what the media is saying about them, there is so much judgment about weight. There's this icky morality thing that's happening around it. In fact, the number of times I've had my own patients go to their GP to ask for help with this, and they get a bunch of sort of anti-fat, anti-obesity things that get thrown in their face instead of real help. And this is at a time where, and then of course they come back and tell me, and I hear about these things. It's just bananas. And it mirrors exactly what's happening with menopause care for women. I
Yeah.
mean, that whole being gaslit, being disregarded. Oh, you don't, I had one patient just recently say, oh, my doctor said, well, you don't want to pay $500 a month for that. No, my insurance pays it. And yes, it is much less expensive in Canada than it
Well,
is in the
and
US.
whose job is it to judge that? I'd pay $500 a month for my hormones if it made me feel better. Like I
Exactly.
can't even imagine that. This is the
Yeah.
thing about hormones is I was never, I don't mean to cut you off, but like I never got scared off by that Women's Health Initiative study 20 years ago. I just
Mhm.
kept on prescribing because I knew it was a bogus study because I knew they used progestins instead of progesterone and I knew
Yeah.
better because I had great mentorship around hormones. And so I was just kept on writing the scripts and
Yeah.
everybody's fine and nobody died of anything. Everybody's
Yeah.
good, and I've seen these women who had come in from like experiences you're describing
Mhm.
and we put them on a little something something and it's very affordable and their whole lives are changed
Yes.
and they get
Yes.
their I mean there is no price I would put on pain relief having lived with exceedingly high chronic pain for decades. Like there's no price I would put on,
No,
like
that's right.
I would make that money happen. Right.
Absolutely. Well,
So,
tell us about actually let me preface what I'm about to ask. So, as I was listening to you speak with the other podcasters, quite a few different interviews, I made a list of the kinds of things that you are talking about that can be benefited by the GLP-1 agonist. So I'm just going to read that list and let's have this conversation. Autoimmune disorders, pain management, inflammation, metabolic health, of course. That's ultimately what these drugs were created for. Non-alcoholic fatty liver disease, neuroinflammation. Dr. Tyna, that's the one that stopped me dead in my tracks. My mother had Parkinson's, then it was dementia, and she passed away earlier this year. And
oh, I'm
that,
sorry.
yeah, thank you. And there was always that in my brain, number one, if her doctor had heard her at menopause when she showed up in the doctor's office with depression and was given hormones instead of an antidepressant, which she took until the day she died, maybe we wouldn't have been there. But unfortunately, she didn't live long enough to see the GLP-1s be as popular as they are. She was never offered that, as far as I'm concerned. By the way, diabetes came before all of that other stuff,
Of course. Yeah.
right? Because this is the cascade, right?
Yeah.
So this is the neuroinflammatory conversation is the one that stopped me right in my tracks. Decreased risk of cardiovascular death, heart attack, and strokes associated with the GLP-1 medications. Weight loss, of course. Decreased addictions, especially around alcohol, the food noise conversation, Parkinson's, PCOS, and infertility. And so you're talking, this is not just the four horsemen.
Yeah.
It's
Yeah.
right. It's
And these mechanisms, I believe to be, and we're seeing in the data to be distinct. It's a different mechanism of action, separate and distinct from the weight loss. Because a lot of people will argue, oh, well, if you lose weight, don't those things all happen anyway? Yes. And we
yes,
also
and
get these
exactly.
different benefits that the peptide is imparting. So, my background, I'm a chiropractor. My naturopathic degree gave me access to be able to do injections. So my whole practice was regenerative injection therapies. That's really where my talent was. My bioidentical hormone replacement experience was revolved around pain and regeneration. So I was always trying to get people in a place where the injections would take and also
Mhm.
get their pain down and also try to figure out, is their pain being driven by the hormones or do we really need to inject them? Because I don't need to be slinging needles into somebody if we could just give them a little estrogen, or testosterone,
Yep.
whatever we needed to do. So, and I want to make sure they're anabolic. So that they heal. And the regenerative peptides came on the scene later towards the end of my practice time. I had left big practice in 2018. That's, COVID kind of wrapped things up for me. I was kind of seeing a few patients here and there still and still had my clinic in brick and mortar, but then COVID hit in Oregon and I just wasn't doing that. So, I'm familiar with peptides. I'm familiar with how they work. I wouldn't say I'm like the peptide guru, but I definitely know my main lever pullers and how to utilize them. And I don't have any concern about ever prescribing anything. In fact, I was always taught by my mentor how to prescribe elegantly, which is, I mean, the reason we have the prescription rights we have is because of my mentor actually in Oregon. He got us full scope. He fought diligently for decades for it. And he taught us that if we can prescribe it, we can deprescribe it, right? We can take them off. And so you as a chiropractor, if you can't prescribe it, you're really not allowed to tell a patient like, stop taking this. It doesn't, it's not as kosher according to things. So I was happy to take patients off their drugs, but also I was happy just to take over management of those prescriptions because very often as we improved lifestyle, we could significantly reduce the script dose. So if somebody needed Prozac, for instance, if we could get them down to a dull roar of a tiny dose, it's not my job to decide whether that is keeping them alive and from suicidal ideation, right? Or whatever it's doing. Maybe it is decreasing pain. I mean, SSRIs do have some utility, but my job was just to get the dosages down. And I was thinking the same, and the same with hormones. It was always, what does that person need? I didn't care how old they were. If you were 25 and came to me with a history of chronic head injuries as a gymnast, you're probably going to need some hormones, right? Like your whole endocrine system gets jarred. If you had a lot of hockey players, I had a lot of Canadians as patients because I was a chiropractor and I had my naturopathic license the last year I was in chiropractic college. And so you bet I was taking care of all those Canadian boys who'd had multiple head injuries. Football players, those guys need testosterone early because knocked their systems offline with all that traumatic head injuries. And so now they're in this, they get thrown into metabolic syndrome and they get thrown into low T. And it's not any fault of their lifestyle at this point. It's like the chronic head injuries and concussions. So anyway, my job always entailed me prescribing what was needed to the person in front of me while also obviously doubling down on lifestyle, because none of these things work very well if you're not doing the lifestyle piece. I don't care how high you dose them. None of peptides, hormones, none of it works if you're not dialing in your metabolic health and doing all the lifestyle pieces, like doing the work, as I call it, all the things. So that was my approach with GLP-1s. I thought, well, heck, if somebody needs a tiny bit of thyroid, most GPs and endocrinologists are going to say, oh, your TSH is fine. You don't need anything. And this person is screaming hypothyroid symptoms. I'm going to give them a little touch of thyroid. We might take a quarter of a grain of Armour and cut it up. We might crush it and put it in some water and dilute it down into something drop dosing, even. Like we get the dose to where we get symptom resolution. And that might be tiny, it might be higher. It's not my job to judge that. That's dependent on the individual sitting in front of me. What are our short term goals, long term goals? What's their weight, their age, their gender, their health history, all of it, right? And their body composition and their metabolic health, like what's all of it doing? So I took that approach with the GLP-1s and I thought, well, heck, there's a multitude of uses here. And so I started asking everyone who I knew that was prescribing them if they were using them like this. And everybody told me the same thing. Many of my colleagues were using them in low doses and saying, you certainly don't have to go high, but they were still doing the standard dosing protocol and they were doing it always for weight loss or appetite suppression or metabolic health. There was never a case where they're like, yeah, I'm using it for neurodegeneration or whatever. And so I just started playing with it. And many of my colleagues got on it sort of as a trial themselves to give me feedback. I started talking about it. Many of my followers started sharing with me the impacts they were having. I was early on hearing, I got off of a lifetime of antidepressants with this, my PCOS completely reversed. Lots of stories of pregnancies that were not able to happen prior, men and women, all kinds of like men being able to get their wives pregnant, and because their sperms improved. Yes, the metabolic improvement is going to help all of those things, but I think there's other mechanisms at play. And then I started dabbling with my patients, of course, and because my wheelhouse is pain, I was intimately interested in how that would happen. And my mom was my first guinea pig besides myself and my husband. And she has had Crohn's disease my entire life. And it was undiagnosed until 2019 when she almost died. She was by the time I started her on a tiny dose of semaglutide, she still was having a lot of issues with food restrictions. And obviously, because of Crohn's, you have to be very careful what you ingest. And her weight was kind of going up and down as Crohn's do. I don't know if you know any Crohny patients, but like they'll go up, they'll get heavy set, and then they'll get real lean and waste away and look like they're dying. And it's kind of the swing, and it's real dependent on how their immune system's behaving and what their gut's doing. It's a difficult issue, and they get polyarthralgia. So she was plagued with pain throughout her entire body my whole life, and she never complained, tough as a nail. And I put her on this tiny little wee dose of semaglutide and all of her joint pain goes away. Her gut regulates and she can eat again. So she's actually putting on good, healthy weight, stabilizing weight. But there's appetite control with the semaglutide so she doesn't go overboard. The swings stopped happening, but all the pain is gone. And I was like, holy smokes, the amount of drugs and ibuprofen and things that we've tried over the years, the injections, everything that we've tried, the joint replacements, all of it, might be mitigated by this minuscule dose of semaglutide, right? So that was really exciting for me. And it's just snowballed from there. And I've got a pretty sizable following at this point. And to hear, I get thousands of messages, hundreds of people sharing with me really, really compelling, life-changing impacts with these peptides. So
which is just amazing. So tell us a little bit about, because as chiropractors, for me, I'm very interested in the musculoskeletal syndrome of menopause. We're really just starting to understand that and what's involved in that. And the pain management situation. That's what we do as chiropractors for the most part is actually handle people's pain. So
yeah.
what have you seen with give us some scenarios, what you've seen with the pain management and the GLPs.
So I've been using hormones for pain for decades. Like this concept of the musculoskeletal syndrome of menopause is very exciting that it's finally being acknowledged. But like my mentor taught me that a long time ago. So when a patient would come in with a frozen shoulder or chronic migraines or chronic anything, we test and dealt with hormones first and foremost before I ever did. I mean, I would treat them, I would adjust them or inject them prophylactically, but or just for symptom relief. But it wasn't really, the root was always to have, we had to get their metabolic health and we had to get their hormones in balance for that pain to resolve or for that shoulder to free back up. And so I chuckle a little when I hear that this is like a newer concept, not negating you by any means, but you know what I mean? Like, you know how it is when you've
I
been
do.
plugging away in your clinic for decades doing something and people are like, there's a new
Now,
thing. And I'm like, it's not that new.
that's not that. Well, and it really just comes down to when we get the research behind it, we get the,
I
the data,
know.
then medicine starts to pay attention. And
I
then it's,
know.
people are like, oh, well, should I talk to my doctor? Well, you've been talking to this doctor for years
Yeah.
about that, but
I
whatever.
know.
Sorry to interrupt. Tina, please go
No,
ahead.
no, I know you get it. That's why I shared
I
that.
do.
I am excited that there are people taking the charge on this, and Dr. Vonda Wright is really a kick-ass lady. So I'm
She's
not dissing
awesome.
anybody, but you know what I'm saying.
Mhm.
You're right. We need the data for everyone to believe what we've been saying. I can't tell you how many people would walk in my door and they were like, "How does my estrogen have anything to do with my chronic knee pain?" And I'm like, "Oh, honey, it's everything right now. Like, I'm not going to
Can we,
put three
yeah.
thousand dollars worth of stem cells in your knee until you get your hormones dealt with
And
first."
can we talk about how progesterone affects the knee too? I mean, that's a
Oh,
big
all
thing
of
too.
it. Yeah,
Anyways,
all of it. Yeah, all of
yeah.
it. It's so
Yes.
anyway,
Yes.
that's where I was thinking with GLP-1. So my podcast producer really wanted me to do an episode about Ozempic years ago. And I was like, no, 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 no. I don't like talking about weight loss. I really don't. My whole platform has been about getting strong, strong over skinny. I know other people have appropriated that term too now, but I have been beating this drum for, I don't even know how long, like to the point where I'm tired of it. And I think that when you start building muscle, you at least, if you're somebody who's going to carry a lot of adipose tissue, you're at least improving your metabolic health, right? And so fitness is really the goal. Strength is the goal. It's less about the, oh, I want to lose fat. So, or weight, I should say. So I didn't want to do it. And I begrudgingly was like, fine, if I'm going to talk about this, I have to research it first and I have to understand it better. So I was calling everybody I knew to get the expert on the topic, but nobody wanted to talk about it. Nobody wanted to like admit they were prescribing it. And so I started researching. And the first thing I look at whenever I research something is neuroinflammation in the brain. The next place I go to is pain. And then the next place I go to is like downstream musculoskeletal. So, I mean, pain from a central take and then what's happening actually in the joints. And so I did that 1, 2, 3, and I was blown away. I was just blown away by what I found. In fact, this peptide was originally looked at before it was ever even, it was discovered. It was looked at for neuroregeneration. Then it was orphaned. And then they brought it back. Novo Nordisk, scientists at Novo Nordisk brought it back online because it had such remarkable impacts on type 2 diabetes. And then after years of it being years and years of it, 18 years of it being used for diabetes, they were like, well, it really helps people lose weight quite well. That's when the conversation started with semaglutide and the FDA approval like 2 years ago, 2.5 years ago for weight loss. And then everybody went bonkers and started vilifying it, which was bizarre. That's a whole other thing we could talk about. Anyway, the pain part. So it's made in the brain. It's not just made in the gut. We make it endogenously in our gut and our L cells, and that's where everybody thinks it stays. And most of your listeners probably understand it as it, slows gastric motility and it decreases appetite. Well, the way it decreases appetite is centrally in the brain. And a lot of papers, even the good literature out there, talks about it crossing the blood-brain barrier. No, it's made in the brain. It's made in a few centers in the brain. There's receptors all throughout our brain. There's receptors all throughout our body for this peptide. It just serendipitously got FDA approved and used for type 2 diabetes. That is not the main, I don't believe that's the main mechanism inside the body. I think that just happens to be a part of it. And there's many signaling peptide hormones that act on our brain to control appetite and to control behavior. Those are leptin, ghrelin. I don't think those are just appetite peptides either. Those, there's a book called The Secret Life of Fat. It's such a good read. It's basically this PhD went through and researched how all of these peptides came to be. I don't think she talks about GLP-1 in there. It was written several years ago. She basically shows how the conversation around anytime any scientist discovered anything about fat or weight loss, their work, they were dismissed, they were ignored, and their work was basically like completely snuffed out. because the fatophobia and the obesity bias is so deep in the scientific community that their peers and the folks at these big journals wouldn't even publish their data, and that universities they worked at didn't want them talking about it because the conclusion is you just eat less and move more, and that's it. It's calories in, calories out. And if we change it now, you'll be infuriated when you read that book. It's just like you can't, each chapter you're like, are you kidding me? This is what happened. So it goes back, right? This goes deep, and this
I'm
peptide
getting hot just listening to you say those things.
just wild. I mean, it's been a real eye opener, and the way that I've been attacked since talking about these has really shown me the obesity bias that people are carrying. It's kind of sick. Some of the podcasts I've even been on, it's just kind of sickening the way that some of them have opened up, and I'm like, really? Like that's really what you think?
Well,
You
and I
know.
want to say to you, thank you for for having such kindness about this subject. Because every
Thank
time
you.
I've heard you say, you say the fighting weight, which I really enjoy that, the talking about the fighting weight, or has people have a bit of fluff. As somebody who's experienced the obesity bias myself for many, many years, it's so refreshing to hear someone talk about it from a real compassionate place. And that's part of the reason why we have not on this show talked about this very thing yet, because I want to bring it in a place where it's supportive for women. It is not more morality driven, bias revealing crap, because we get so much of that. And for those of us in the Gen X perimenopausal phase right now, we were raised surrounded by the diet industry.
I
And
know. And we
it
all
takes
wrecked our
us,
metabolisms with over-the-counter diet pills, huh?
yes, that's what my mother taught me you did. This is how you
I know.
self-flagellate. You starve yourself. You go on these awful diets and, whatever else. And so, but that's what the generation was at the time. And so, what I find really interesting is any conversation in the clinic about weight loss or perimenopausal weight gain or fasting or GLP-1s, it's such a fine line for so many women for them to hook into that old behavior of starvation to make themselves look good. And because I grew up in that as well, I can see it. I go get so I just avoid it for the most part. But Dr. Tina, you've had such a compassionate voice on this, and I just want to thank you for that.
Well, thank you, because I will admit I had my own fatophobia. I had a older sister who was quite obese, and she was very abusive to me growing up. And so I just sort of like pigeoned. I just, like when somebody looks a certain way and then they hurt you, you just sort of, I carried it around. And this journey has been really eye-opening to me. And I have spent a ton of time and money on a lot of the mainstream obesity medicine that's out there, like, the Obesity Society and some of their webinars. And I try to watch and listen to everything I can that's coming out on any conversation around GLP-1s. And I've learned a lot. I think that something really important to share is that the one big take home for me, and this is something it was hard during COVID because I was very much trying to get people to understand that the reason North America was having such a terrible time with that virus was because our metabolic health was in such a disastrous place, and 94% of US adults are cardiometabolically compromised. So we've got a lot of busted metabolic health out there. And as I was trying to get that message out, I got called fatophobic a lot. I had a lot of people attacking me because I was pushing back again. I mean, they did not want me talking about how you could actually do something to bolster your health and that you were not a sitting duck in the face of what was happening. And I was telling people to go outside, eat meat, and go out in the sun and lift weights. And I was getting massively censored and attacked. And it went deep, like political attacks, merchant services shut off, deplatforming, like all kinds of stuff. This is outside of the intervention that came in 2021. This is just me. They did not want us knowing that you could be healthy and that you did not need to fear everything. And I got called fatophobic so many times during that period. And I was like, my daughter is the one who was editing my podcast at the time, or the video, I should say. And she was like, Mom, they don't understand. You're just trying to help people. And I'm like, I know, but this is such a delicate and sensitive and emotionally charged conversation and topic. And who am I to come at it like skinny white girl to come at it and say I have any experience with this? But everybody in my family eventually ended up obese. And so I was like the token lean person. And I really had to start working to stay in that place, but I get it. And there is epigenetic changes that happen when the mother is metabolically compromised and swimming in insulin herself because of insulin resistance, that fetus is then swimming in insulin inside the womb. And that child is epigenetically marked for extremely high risk for obesity and type 2 diabetes in their lifetime. And we are a few generations into this phenomenon. And so there's so many people struggling and to no fault of their own and to like literally, I don't want to say it's a genetic condition because I think there's two arguments I've been hearing, and I cannot pretend to speak to this with any authority because I have never been in a place where I've been a heavy set woman. But from what I understand, I will just say what I know and with compassion. The argument I hear as I've been on this podcast circuit is over here, they're saying, well, if we say that obesity is genetic, then that gives everybody an out just to make excuses and go pharmaceutical intervention first. And then the health at every size community over here is saying a very valid argument. Like we have fought so hard to undo this stigma. And now you're telling us we need to be smaller and they're pissed off about the Ozempic. And again, I'm not in either side. This is what I keep hearing from both sides. I'm kind of wrapping it up. And then the skinny girls are kind of pissed off because now they've got legit competition. and and the heavyset girls are pissed off because they're like, why are you telling me that I need to lose weight? And I'm not saying any of that.
No, of course
I'm
not.
trying to share here that we have a peptide that regardless of what size you're at, could potentially help you with a myriad of other conditions. That said, this low dose strategy or this strategy, like the microdosing term, I wish I never used it. This strategy of low doses may not be a weight loss strategy.
Yeah.
It may help some people kind of lose the fluff, but if you've got 30, 40 pounds to lose, you may actually need a more standard dosing protocol. And in that case, I do believe we can still go very slow and low and be moderate about this and be thoughtful. And like my dad, for instance, very obese, has spent a decade or more, God, at this point, in a lazy boy and was really on his way out the door with diabetes. And I put him on a very low dose. We've been very, very cautious. I've got him up to just like half of the standard high dose. And it's taken a full year versus the way that the studies show and the way that most doctors do it is they put you on the standard starting dose and they double it. They double it usually they double it every month, every 4 weeks. And then they take you up to 10 times the dose they started you at. Whereas my argument has been like, hey, can we slow the roll here so that the body can adapt? It took a few months. All of a sudden he perked up. All of a sudden he started talking to us again. I mean, my dad was not in good shape. Then he started making jokes. Then he started getting sassy. That's where I get all my sass from. Then he started wanting to move. He wanted to go for walks. And now he's got a puppy and little shifts, but none of this. We had a fully cognizant conversation with my dad at Thanksgiving, which we hadn't had in years. And I was like, dude, semaglutide gave me my dad back. So that long-winded to say, I don't understand what it feels like to live in a large size body, but I do understand the devastating impact it has on people. I've helped many patients lose a lot of weight. I've had many patients come in at 300-400 pounds that I've helped lose a lot of weight, and it's been hard. We used HCG, we used hormones, we used all the things. But what people don't understand is when you lose the weight, now you're at a new set point, but your body desperately wants to go back to the old set point. And the way that the leptin system works and the ghrelin and all of those things, your body it is harder as a large size person who's lost weight and gotten leaner. It is 10 times harder to maintain that than it was even to stay at the larger size. Like the way that the body doesn't want to let you stay there. There's lots of factors involved, but somebody described it well. They said, if you had to run 4 miles a day to lose a pound, now you have to run 5 because you don't have the leptin present because the adipose cells are not there secreting the leptin, controlling the appetite. So either way, no matter how hard somebody works, the point being, no matter how hard somebody works, and if we want to go to the willpower, which I don't think it is, but if somebody
definitely not.
It's not. Somebody busts their ass. They lose the weight. You've probably experienced this yourself. I've watched many of my family members, many of my patients. it's almost like the weight loss itself shoots you in the foot metabolically. And now we have a tool. We have this beautiful tool. So even if we're not just using it for all the other wonderful benefits that the data is showing it may derive, we have this tool for folks who really don't want to live in a state of chronic excess adiposity and not feeling good and like it hurts,
Yeah.
like physical
Yeah.
pain, mental anguish. They want to rejoin society. One of my daughter's friends, finally, she was really against it. I've known her since she was 16. She's gained a tremendous amount of weight into her 20s and was just isolated and not living any kind of life for years, just completely holed up in her house, went to work, came home. And she is now like wearing shorts and she's lost so much weight. She's not lean, but she did listen and she did do a more reasonable approach. So she's just kind of lost the weight down to the size that gets her moving and feeling comfortable. She's still a curvy girl. She looks fantastic and she's out there. She's like going to the beach and wearing shorts and living her life. And
Good
that
for
makes
her.
me want to cry because this tool enabled that and it was done
Yes.
appropriately.
Yeah, and I think, the most important part of the conversation, I think around the weight loss situation is we've made it about weight, which has a bunch of emotionality, a bunch of feelings, a bunch of history for a lot of people. What did you say? 94% of Americans are cardiometabolically unhealthy. Was that the word? Is that?
Yeah, and they don't
Yeah.
even know it,
Yeah.
and of the people of that group, a huge percentage are dealing with excess weight.
Yeah. Well, and there hasn't really been great information for, as you said, it's been the whole calories in, calories out conversation. And look, I know this is true for me and it's true for a lot of people. We did that and it wasn't a good enough, it didn't solve the problem,
If it
right? So
worked, we wouldn't have the problem, right?
exactly, exactly. So
Because I
obviously,
know disciplined folks that are way more disciplined than I who
exactly. So it's obviously a neurochemical and biochemical conversation, not as behavioral as it's made out to be, although that certainly is part of it. But again, it's an individual thing. This is why we do precision medicine. It's different for everybody. To paint everybody with the same brush is, well, frankly, that's what medicine does. I don't know if I'm allowed to say that. Ooh, shit disturbing.
well, it's just I didn't know that I really didn't know that I did not have a clue that I was about to like unleash the Kraken when I started talking
Yeah,
about
you
this.
did.
I thought I was just talking about the way that I do things. This is the way I've always done stuff, this is the way I've always done hormones in clinic. And this is not a steroid hormone, but this is a hormone. It's a signaling peptide hormone. And I just thought, oh, well, this seems reasonable. If somebody's presenting the idea that I brought up that I've taken the most heat for is this idea of like a functional deficiency. And
Oh, yes.
the way I would describe that is like I mentioned with the thyroid, I would see that often with hormones, a functional deficiency. You burn your HPA axis out from whatever, stress,
Take your pick.
viruses, head injuries, whatever. And you might need a little something, something. They might need a little
Yeah.
progesterone, a little estrogen, a little testosterone. In 2019, I did a presentation on women need testosterone too. And that blew up, not like this, but that blew up pretty big too. And people were like, what? Women can take testosterone? Nobody was talking about it at the time, except for a couple pain medicine docs I knew. And here
Yeah.
I was like, it went crazy on YouTube. And I took a lot of heat for that. And I was like, what? You guys aren't doing this? Like, I didn't know that people weren't doing this kind of medicine in their clinics. And so I guess I've just been in a bubble. I've just been trucking away doing my thing. Anyway, I digress. But the peptide conversation really, for me, was the same thing. I was like, what if people's L cells, most of our patients have leaky gut, and most people's guts, most people will complain to some degree about some something gastrointestinal as a symptomology, right? Like maybe a little IBS, maybe a little reflux, something. Most people have a little something, something when it comes to their digestion. And I got to thinking, well, also as we age, our gut lining atrophies. So I think a lot of people's L cells might just be in piss poor shape. Like maybe their L cells are just petered out and they're not making GLP-1. And then I thought, well, I wonder if there's a deficiency. So I went looking, and of course there's data showing that those folks with fatty liver and type 2 diabetes, i.e. metabolically compromised individuals. You get fatty liver infiltrate when your metabolism is screwed up and your insulin is all catawampy. So those folks actually have GLP-1 deficiency showing, and it probably is functional, meaning it was induced by the process of time and pathology. And then I thought, well, what about obese folks? Are they genetically deficient? Are they like, what's going on? And there was a study that came out a few years ago where they fed individuals fats, carbs, protein, and they had a normal, compared to their lean counterparts, they had a normal GLP-1 response to everything except for carbohydrates. They had virtually no GLP-1 secretion. Like, you're supposed to eat, the food bolus goes through, it hits the L cells of the intestines, and the GLP-1 is secreted in response, chemically and mechanically. The bolus of food actually causes it, but then the chemical makeup of the food you're eating. And they did not have a very robust GLP. The obese folks did not have a robust GLP-1 secretion in the presence of carbohydrates. So what does that tell you? I mean, ultra refined carbs are already addictive enough, but quite literally, these people are not getting the response of satiation and fullness when they eat carbohydrates specifically, due to we don't know why, because it's like there's not follow-up studies, because who knows why. But I do think there's something there, and I think that potentially people are burning out their guts with poor health and poor food. I know I did for decades. I ate so badly for decades. I was anorexic, I was bulimic, and I trashed my gut. And so who knows if these folks, and then I got to thinking, what if there's a GLP-1 deficiency in the brain from, say, chronic stress or chronic chemical exposure or chronic head injuries or concussions? Maybe those folks are just not secreting adequate GLP-1 either. We know very often when people get a bad head injury, they often get obese after. Like, obesity comes secondarily very quickly. Like I said, their metabolic health gets compromised. My dad had 2 aneurysms, and next thing we know, he's 300 pounds.
Yeah.
And, you know, and he wasn't he always had a belly, but he was a skinny dude. So this just goes to show that there's mechanisms at play that we don't understand. And I think GLP-1 may be part of the conversation.
Yeah, and it seems to be that is thanks to your information and the pioneering conversation that you started. I've gone into the data too, and I am shocked that we're not having a much larger conversation about this based on what I'm looking at in the data. And it almost feels like it's been repressed.
Yeah, I agree. I agree. Well, because the Alzheimer's industry is that's type 3 diabetes. We've known that for 20 years.
Yes. Yeah.
And they had all their fancy drugs. It's funny, my background was that's where I started in medicine, was in an Alzheimer's clinic at Oregon Health Sciences University, like way back in undergrad. Yeah, their drugs are garbage. And a couple of years ago, you saw the studies come out like, well, everything we thought was wrong and nothing's working. Nothing that we have spent billions of dollars on is working, and we don't know what to do. We don't have anything in the pipeline. Good luck, Alzheimer's patients. And I'm over here saying like, well, we have some pretty damn good data with GLP-1s, don't we? In rodents and in humans, like the I mean, there's stacks of studies on neurology and GLP-1s that I've gone through. And just every time I'm like, holy shit.
Well, and the one that
if I can say that, like, I'm just like,
please
what?
do. Oh yes, we cuss on this podcast. Go ahead.
It literally undoes, from what I understand, it like undoes it, the misfolded proteins, all of the damage that comes with Alzheimer's. GLP-1 has a positive impact on all of these different mechanisms of pathology that are occurring in that disease process. And I'm like, why is nobody blasting this from the rooftops?
Yes, it's very true. AG1, the way I start my healthy days. With my AG1, I get a daily dose of vitamins, minerals, pre- and probiotics, adaptogens, and more. It's daily self-care for my busy life. It helps me fill the nutrition gaps, supports immune health, and supports gut for healthy digestion. It's once a day, easy to drink, and packed with bioavailable ingredients in a convenient formula. I am proud to have had AG1 as a sponsor of this show for many years. It's a nutritional supplement I stand behind and I take every single day. Start with AG1 and notice the difference for yourself. It's a great first step to investing in your health. Try AG1 and get a free bottle of vitamin D3, K2, and 5 free AG1 travel packs with your first purchase at drinkag1.com/Fiona Lovely. That's a $48 value for free if you go to drinkag1.com/Fiona Lovely. Check it out. I know the one that blew my mind was looking at one of the Parkinson studies and talking about how the GLP-1s work on the dopaminergic pathways in the brain. And I was like, okay, is this why we're hearing? Okay, so if it's somebody in front of us is not have Parkinson's, but they're having that experience of being on the GLPs and that food noise disappears altogether. And then the addictive qualities that they had, maybe they're not maybe they're not smoking as much, which you shouldn't be smoking, or vaping or whatever, gambling or shopping or eating or whatever, obviously those things. But I can't help but wonder if the food noise and the dopaminergic pathways, there's just got to be something it's all got to be part of the same thing on the go.
It is. It is. And they did a study in rats that they Johan Hari, I don't know if you know who he is. He's an author. He wrote the book called Magic Pill that came out last year, and
Yes.
it was an investigative deep dive into GLP-1s. Really beautiful book. I think he was an obese man himself, and he does a really beautiful job of laying out all the different variables that I think are worth having in this conversation. I need to get him on my podcast because he just did such a good job with it. But he talks about a study in there, and he links all of his studies on his website, which is really cool. You can get them there too. But he talks about one where they looked at rodents and they had these rodents eating rat chow, or they had them eating like kind of a cheesecake, if you will. It was like this the perfect bliss point food, the emulsification of fat and sugar and, just that, like you just can keep eating it kind of thing. And when they were put on semaglutide, they still ate, but they preferentially ate the rat chow, and they stopped gorging themselves on the cheesecake.
Isn't that fascinating?
So it's not like it shuts it down completely. And I know a lot of critics will say it makes you suicidal and it shuts down your desire to live. That is not true. I will say, I do think that depending on the individual using it, again, it's always individualized medicine. I think you can push the dose too high and you can kind of take the luster out. And I think there's a couple things at play. I'm just guessing based on folks that I've talked to, but and I've had it happen to me where I'm like, I don't want anything right now. And that's a little too high of a dose. I don't want to crush someone's appetite, right? I just want control. And I mean control of everything. I don't just want control of their appetite. Like I have such better control mechanisms when I am on a GLP-1. I just make better decisions and the world's a bit
Wow.
calmer place. But I think
It's
that
got to be involved in the reward pathway with
it
dopamine. It has
is.
to be.
It does. It impacts the dopaminergic reward pathway. And I think for folks who are taking too high of a dose, it can kind of blunt everything. And so my husband is a good example. He's on it for cardiovascular health reasons. And he'll say, like, I don't want anything. I don't want wine. I don't want chocolate. I don't want to eat. I don't want sex. Like, I just don't want anything. And I'm like, okay, that dose is too high. That's not what we want. We got to dial it back. And it's a tiny, tiny little bit. It's the littlest bit that we have to change it. That's why I say get with someone who knows what they're doing so that you can play with that dose, because in the right person, a little bit too much is a lot too much. The thinner they get too, the leaner somebody is, the dosing really gets, you got to be very careful because the tiniest little bit can send them way over the edge. But I've got people telling me they don't doom scroll on Facebook anymore or on social media. People have stopped online shopping like crazy, all kinds of control mechanisms that have been given to them, been given back the onus of control when taking a GLP-1. It's just wild. The list is endless of what people have shared with me. But I think with the suicide conversation, there's a lot of misinformation going on around that right now. The data is very clear that these generally very much boost mood and decrease anxiety in people and make people feel way, way better. And most people will be like, I feel so freaking good on these. However, that said, I could imagine if you did have some doctor cranking up your dose and you were on way too high of a dose and you've lost your libido and you kind of like are losing your luster for life, maybe food is also that person's dopamine dragon, right? Like food is how they comfort themselves or
Mm-hmm.
self-soothe. And now there's no interest in food. And then, but they're not given any other tools or taught any other
Yeah.
ways, right? So I could imagine that would be a very difficult place to be. But the data that did show a signal, at least to pay attention to, with suicidal ideation. The only one that's really come out and shown this to be in any way, shape, or form, like have actual numbers. It was correlative. They looked at millions and millions of people. They didn't look at them. They looked at their chart notes over a period of time, like 20 years. And they found, I think it was 107 or 117. I can't remember exactly. It was 100 something people on semaglutide that had suicidal ideation out of millions over 20 years. And what they concluded in that group was that those folks in general were also on antidepressants and benzodiazepines. So the
Mm.
conclusion of, first of all, the authors gave multiple limitations to that study. And the conclusion was, don't throw out the baby with the bathwater, be cognizant and screen your patients for any kind of low mood, depression, suicidal ideation before you put them on a GLP-1. But there certainly was no causative link. And there wasn't even a link strong enough to say, oh, you should discontinue. It was more of a, we've been tasked to look into this. This is the signal we found. Let's pay attention to this. So I just want to put people's minds at ease. I really don't think that there's a huge risk there, but I will say I've had people come back and say, I'm kind of just like, I'm feeling kind of meh. And it's not a depression, it's just sort of flatness. But again, it's not my place to judge what that flatness is for them. So we just dial back the dose.
Mm. Yeah, interesting. Well, and what I've seen quite often is that if the doctor is willing to prescribe, then there's no tools given. And what I mean by tools is I'm going to share a story about my husband who takes semaglutide for diabetes, type 2 diabetes. And he's done really well with it. He's lost 60 pounds. His blood sugar is much better. And he's been on it for a few years now at this point. But there was a moment where I could tell his dose was too high because he was forcing himself to eat. And the forcing self to eat for him, all of a sudden, he does the grocery shopping in our house. All of a sudden, weird Frankenfoods were showing up in my pantry. And I'm like, why is there fucking nacho cheese in the pantry? Like we make that from scratch. Why is this here? Like, and ramen noodles and things like that. And I'm like, what in the hell? It's like
Oh, he
back.
was trying to spark his appetite.
He was. Now, what was interesting was that his endocrinologist said that a half dose was not going to be enough to control his blood sugar, and in fact, that has been the case. So for him, and again, this is a different conversation. Just to clarify for people who are listening, than Dr. Tina and I have just had is. For him, it's about diabetes management, which is actually what these drugs were created for. What you and I have been talking about for the most part is getting that metabolic health better so that we don't become diabetic,
Yeah,
which is
because
a
diabetes is like way down the line. And if you've got 15, 20 years of devastation to your metabolic and mitochondrial health during that process of getting to that magic number of diabetes. So I'm all
yes,
about like, let's nip this in the bud early. First signs,
100%.
first glimmers on labs. When that middle-aged woman walks into my clinic and says,
Mhm.
I have not changed anything. I turned 48. I've got
Uh-huh.
15 pounds around my midsection.
My triglycerides went up. My thyroid's gone down. Yeah, like all those
I'm
things, right?
like, that's insulin
Yeah.
resistance starting. And
Yeah.
why do we wait 10, 20 years? I feel so bad for our generation. I mean, at least our generation had a little bit of hope as far as the food supply wasn't completely adulterated when we were kids. I mean, it was not great, but a whole generation of women got, right, like just before us, like my sister's age generation, just got completely screwed over when it came to hormone replacement and just have had to white knuckle it through. I can't even imagine. So there's so
I
many
know.
upsides to the brain. It was
Yeah.
Dr. Moscone, her work, right?
Of
Like
course. Of course.
her work around the brain and the estrogen receptors finally giving
Hmm.
us some images to compare to our lived experiences,
Now,
of
now we're
like,
having now we're having a different conversation. When a woman starts to have a low mood at perimenopause, is not because it's all of a sudden sudden onset depression. There's so many things involved. What are her hormones doing? What's the insulin sensitivity situation, etc. On and on, right? But to go back to this toolkit, so what I'm seeing quite often is patients are going to the doctor saying, all right, like here's the medication, go ahead and take it. This is how you take it. You up it you double it every month kind of thing, to a certain point, but not being told the two most important things, which are you must prioritize protein, number one,
Yes.
and you must prioritize muscle building.
Right.
So those
And
two things are really important. Please share more. Talk about
well,
that, please.
those are like non-negotiable anyway, right? That's all I was gonna say. I don't mean to cut you off. That's
No,
just
it's
like
okay.
that's just what we should be doing anyway as women, period.
But
As
nobody taught
humans.
us.
I
Nobody taught
know.
us,
I
Tina.
know.
That's the thing.
I've been trying. They keep censoring me. I keep
And you
trying.
know why? You because this is
I've been saying strength training is non-negotiable for well over a decade online, and it's just taken so much heat. And people are like, "Well, people are going to do the exercise they want to do," and I'm like, "That's great. You still have to build muscle. It's non-negotiable. It's not, especially
yes,
ladies, our bone mass. Like,
it's so
I don't want to
important.
break a hip, you know."
No, by the way, that was my favorite quote. I have it written on a post-it note here somewhere that said, "This is what you said to your trainer: Give me an ass, and I don't want to break a hip."
Yes. And I'm really just training for the zombie apocalypse at the end of the
Oh,
day. So I've that's been the jam for 10 years, solid. If you
yes,
hear anyone else repeating my words, now you know
that's
where they
you.
came from. I just think that we really we really absolutely need to prioritize our wellness in almost a selfish way.
Mhm.
However, that said, I know how frustrating it is when you are doing all the things. Unfortunately, we've got this cortisol balance, right? We're the most stressed out group of people. I think middle-aged women are probably the most stressed in general. And then you add to that that precipitous drop in estrogen, which turned me into a Looney Tune. It was so awful when my estrogen just fell out from
Yep.
underneath me. And it was out of nowhere. I was great. I was in the best shape of my life. I was happy. My libido was good. Everything was good. And then chronic stress from pushing back against the censorship industrial complex, them coming at me, and then it all bottomed out. And then the harder you try to do all the things, the more you're driving the cortisol and the heavier you get. So it's
Yes.
like this vicious cycle that you're in where you're like, I'm doing everything right. And I get so many messages from women. I'm doing everything right, Dr. Tina. What? I'm doing everything you tell me to do. I bought all your courses. I don't know what else to do. And I'm like, oh, you guys, I discovered something. We
Yeah.
have the peptide. Like
Yes.
we have
Yes.
the perimenopausal woman's BFF triad is the HRT, the strength
Yep.
training, and now we got the GLP-1. And if we do all of these things, that's why these things are non-negotiable because to keep that dose as low as possible, we need to be doing all the things. Otherwise, you're going to chew right through the peptide. Literally, you're going to eat right through it or drink right through it, and you're going to have to just keep cranking up the dose for it to be effective. And then we end up with receptor issues where the receptors are no longer sensitive and they're not hearing the hormone or the peptide. We get this with HRT too. So it's I used to make my HRT men and women patients sign a contract. Like 10 years ago, there was a contract that said you will follow, at the time it was a paleo diet because that was the best description of a low carb diet we had.
Yep.
You will strength train 2 to 3 times a week. You will limit your alcohol intake. And of course, I couldn't keep these people, I couldn't make them do it. But if they came in and their labs were all over the place and they were like, I kind of been screwing around, I'm like, I'm not going to keep writing the script because hormones go down bad pathways when there's excess adipose and inflammation in the system. So
Mhm.
just to keep everything clean, we really do need to focus. This is the other part that I'm excited about is in those patients, those women who desperately needed hormones, but they were carrying around excess adiposity and they were dealing with a lot of inflammation. I hate to put estrogen in that body because it doesn't always go down the best pathways. And it's really like trying to hit a moving target, even if they're doing all the right things. Now we have a tool that can clean up the terrain. We can
Mhm.
clean up that excess inflammation and sop it up. And then we do the muscle building to suck up all that excess glucose and we get that metabolic system dialed in to some degree with the GLP-1. And now the hormones are, I believe, safer and going to be more effective, and we can keep the dose lower. And I have a better idea of clinical outcomes. I can say with more authority, you're going to feel better on this. Whereas before, if I had somebody come in, especially if their diet was a wreck and they really were kind of like fucking around and not taking good care of themselves, I was not going to put hormones in that body. Progesterone, maybe, but definitely not estrogen and testosterone because those go down crazy pathways when somebody's not taking good care and doing the work. So I just think it's such a great tool in our toolbox now.
Yes, absolutely. The estrogen cliff. Let's talk about that for a minute.
That is a
That
cliff.
is, it is a cliff and it sucks. I
Yeah.
had the experience of it spring of 2023 and I didn't even, this is the thing I know my husband said to me, he's like, you're the expert at this and you didn't even know what was happening. I know this is the crazy part. Like, for women that
Terrible.
have no education around this at all, which is most women, like how do you even know? You think because what our society has taught us to do is to internalize everything and everything is our fault. And so we've done something wrong. And but I'm telling you, when I fell off that cliff, it was grim, man. It was grim. It's the closest thing I've ever felt in my life to whatever depression must feel like. Just it's like the light just went out.
Yep.
It was
Yep.
brutal. And when I looked at the numbers, I had gone from almost 1,000 estrogen, too much, down to about 250. And so that is a huge leap, and that happened in about 3 months' time. So there's a lot to be said about that, and that discussion I think is an important thing. And you've had it, I've had it. If you're experiencing it, you didn't do anything wrong. It's just part of perimenopause, and have somebody look at your hormones and optimize your hormones. Let's go back to the strength training thing because I think this is a
Okay.
great place for us to wrap. For myself and a lot of women in our age group, strength training in a gym with weights is scary AF.
Yeah. I know.
How do we get there?
Okay, so I want to say something about your last point though, just to share with the audience. When I was 15, the lights went out on me and I tried to kill myself and I ended up in the psych ward for a week. And I came out of it and nobody could figure out what had happened to me. And I spent 15 years on antidepressants and it was terrible. And I found my path to health through my studies in, many of us go to school, we go to chiropractic college, naturopathic college to find our way out, right?
Mhm.
And strength training came to me later. I didn't start it until I was about 40. Um, and by then, my health was in much better condition and my mental fortitude was in much better condition. And I started strength training, and it was like the sea opened and I found my calm. I found my place. I found my warrior goddess, if you will. I found
Yes,
this
please.
place of refuge where I could go train out my demons because we're Gen X, right? We're just filled with them. And
Angst.
just so much angst. Yes, I was an angsty teen. And
Pissed off coming out the womb. Anyways.
yeah, I was pissed off. I'm a fighter. I will like throw fists if I need to at any given point. So it's to this day. So strength training to me was like this amazing place that kept the demons at bay. And then for me, when I went off the estrogen cliff, I was actually on estrogen. I was taking topical estrogen. I thought I was doing the best I could. My labs actually looked okay, and I still fell off the cliff. And I went to such a dark, heavy place that I had not experienced that level of suicidal ideation since that teenage episode. I mean, I really fell into a hole and I didn't think I was going to come out of it, and I didn't care. I remember spending an entire summer feeling so much apathy that I didn't care. I was going to get in my truck and with my dog and drive away and never talk to my family again. And I didn't care. And I wasn't even mad at them. I mean, I'm just sharing this because I know a lot of women go through this and they're just put on an antidepressant and told to get over it. And I'm telling you guys, it's your hormones. So I'll leave it at that. Because when I got on steady state estrogen, when I got on the patch, and I coupled that with the GLP-1, it was night and day. And I feel like such a calm, just reserved, strong. I'm like stepping into that really good crone energy now, and I'm embracing it and it's great. So get the hormones, ladies, spend the money, do whatever you got to do. Okay. So strength training, that's it. Like it is, we are all warrior goddesses and we have been conditioned by society to be a certain way. And I'm telling you, inside of all of us, and some more than others, is a fighter. And the gym is the place for that. The gym is the place to push yourself to the edge of discomfort, feel it and get through it. And you come out with this mental fortitude that I cannot even describe. It's like a superpower. It's a sixth sense. Like you think you're a strong lady now. Wait until you actually physically start throwing heavy shit around. It's like I can't explain it. And on top of it, we could talk about the bone density issue and not breaking a hip. We could talk about the immune boosting benefit, the fact that when we build muscle, we actually put more mitochondria on our bodies. We actually secrete myokines, which are anti-inflammatory. So you're building a suit of anti-inflammatory molecules that you can call upon whenever you need. All of that aside, at the end of the day, I just don't want to be frail. I don't want someone wiping my ass. I don't want to fall down and not be able to get back up. I don't want to have to call upon my husband every single time I need something to happen. God forbid something happens to him and I can't help him because I'm too weak. God forbid something I've got a great example. I have a 65-pound dog. She's blown out both of her ACLs out here on the farm because she estrogen when you neuter and spay your dogs at 6 months old, which is what the shelters do, you essentially throw them into surgical menopause. And they now know that, and there's a lot of literature coming out that we should wait until they're well over 2 years old, and either for either gender, because these dogs are plagued, especially the female dogs, are plagued with ACL injuries because of the estrogen loss at
Deficiency. Yep. Yep.
yeah. So
Yep.
so with her, she's blown both of her ACLs. Thank God I can inject her knees and put stem cells in her. So I've like saved her knees. But my husband, we live on a farm and he's like, I grew up in the suburbs. My husband's like, we would have put that dog down by now. That dog has no use. We live the way that our house is built. It's like a spiral staircase. We have to go up 2 flights of stairs from this studio. She's laying right behind me right now. For 2 years, I had to pick her up and carry her up 2 flights of stairs every single night to bring her into the bedroom to go to bed with me. That is why I strength train so that I can pick my 65-pound dog up, because I always say to her, you're lucky you got me. If you had a weak mama, you would have been put to sleep by now, or you would have had crazy surgery, which doesn't really leave them in much better shape than they started in, to be honest. ACL surgeries are not awesome. It's either arthritis now or arthritis later. So I was like, you better thank your, lucky
Lucky
stars,
stars.
your mama
Yes.
squats and deadlifts, because I can be of service. I can be functionally helpful in a way that I couldn't when I wasn't strong. So
And that's
that's
a great example. Now, how do we, give us a practical thing? Like, how do we find a place that feels supportive, that doesn't feel scary? What should we be looking for? Is it a trainer? Is it a group? What is it?
if you have the finances, I would find somebody to work with one on one. And I think it's incredible money spent. I think it's more important and more valuable than your health insurance by far. I would find someone specifically, whether they're male or female, who knows how to train the older adult. I would ask, I don't care if you're young, find someone who knows how to train and has respect for training the older adult. Because my trainer, she always jokes, she's like, anybody can train a 25-year-old. It's very different to, train a 45-year-old. That's a whole different ball game. So somebody that's cognizant. I think right now we're seeing an uptick in this cool, I know you're seeing it probably with a chiropractic. Like, remember back when we started, everybody was on their turfs, everybody stayed separate. Now everybody's really intermingling. So the strength
Yes.
and conditioning community, the chiropractic community, the naturopathic, the functional medicine, everybody's talking to each other, going to the same conferences, going to the same workshops.
Hmm.
So finding somebody who might have a clue about hormones can be really helpful, or at least has a respect for like adrenal and thyroid function, so they don't burn you out. And finding someone that you can work with who you trust and you don't leave feeling worse off than you came in, because it's not about making you feel awful at the end of the workout. You really actually, the first several months, you should leave those workouts thinking, I feel like I could have done more. Like, I don't even feel like they pushed me very hard. Just wait. It's slow and low, because you have to build up those musculotendinous structures. You have to build up that enthesis, right? Where muscle and tendon, ligament and tendon meet bone, because those, if you haven't been training, those are weaker and you're much more prone to snapping them or injury. So find someone who's going to go low and slow with you, who honors where you're at, whether it's your hormones, your age, your orthopedic, faults that you come to the picture. All of us come with like a wonky hip or knee or shoulder or whatever, respecting that. When you say, I can't do this move right now, it really makes my shoulder bark. They don't try to keep making you do it. I've had so many trainers who do. They're like, well, you just need to try harder. No, 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 no. This is not the move for me. At least not right now. It's not until I gain more strength in that joint. So it's a slow and low process. It's a journey. It's not a destination, and you're going to have setbacks. And the goal is that you have someone you can work with that we don't want you getting hurt so that you get set back so far you don't want to do it anymore. If that's not available to you, find a small group if you can. I think that's much more affordable, and you're still going to get some one-on-one, maybe a group of like 4, 5, 6 people, where you've got some individual coaching, but you're still in a group. That's going to give you some community and accountability to the other folks in the group. If you like, I really like training with men. It pushes me. They're very supportive always. And people who are trying to get strong generally are very supportive people. They're always there to help. They're not there to judge you. I've never been in a group of people that was like, oh, look at you, you're so weak. Nothing like that. We're all there to better ourselves. If you don't feel comfortable around training with other men, if you're a woman, then get with a group of women. But I'll tell you, men, there's a magic in men that my friends were always guys, and they really do bring out the best in women when they're good guys. And most
Mhm.
guys who strength train tend to be in that category. So strong men are
Yeah.
always that testosterone. I do think it's contagious. That's what I loved about chiropractic college. You know, when you're with a bunch of dudes that are fit and
Yeah.
healthy, that testosterone is really good for you. So, yeah, just finding a group you're comfortable with. Women can kind of commiserate sometimes and maybe not push themselves hard enough. And so that's why I think, or just finding maybe a group of women who are a little more athletic or used to be more of athletes themselves, just something to give you that it's healthy to have a little bit of competitive edge around you. You know, it doesn't have to be all competition, but like just something to, because then you'll push yourself a little bit harder. And that's it. And stick with it. And don't expect miracles in 90 days. In fact, your clothes might get tighter initially because the muscle's building underneath, and that's going to push all of the tissue out. And so everything's going to feel tighter and you're going to feel defeated. But just hang in there. The goal is not skinny. We're trying to get fit as fuck. We're trying to fight bears. We're trying to survive the zombie apocalypse. You need one good push up. You
Uh,
need one good pull
Please.
up.
We're trying to fight the fucking patriarchy. Come on, let's just be real here. That's what's happening.
I always say I'm small, but I'm mighty. And
Love
that's
it.
it. And I joke with my husband, he weighs 205 pounds and I can deadlift 200. And I think with some adrenaline, I could do 205. And so I tell him like, I have to be able to,
Careful. I'm
I'm
gonna
like,
deadlift you.
but I'm like, I may have to pull you out of a
Yeah.
situation so you don't get to gain more weight and I don't get weaker because I need to
Yes.
be able to help the people that I love. So I don't know. I think of it just much more in a lifestyle sort of way. I want to be able to hike and have hot sex and do all the things I want to do and I want to surf and have all the mobility whatever I feel like I want to do. I'm not good at any of those. Oh, I'm good at the sex, but I'm not good at surfing. Whatever it is I want to do. I want to be able to do it when I'm 80 because I have the
Yes.
strength and mobility. That's what I'm thinking of long term is like, I don't want to end up in a hospital because frailty is the kiss of death. And
Yes.
you can have excess adiposity and have a ton of muscular frailty. And that is no way to go into anything, whether it be cancer, COVID, or just old age. Like that is the
Mhm.
kiss of death. So keep the
Well, this is
inflammation down and keep the muscle up.
keep the muscle up. And this is what I love about this conversation is that it's because Gen X is so scrappy and we are
Yes.
not willing to go quietly and we're not willing to go out like our parents did. Like we just are really changing the whole landscape of
Yeah.
aging. And I say to my younger patients, my nieces too, like just hold on. It'll be much better by the time you go through this because my generation came first and blazed the trail. And today, Dr. Tyna Moore, we got to talk to you, the trailblazer of the trailblazer generation. So I thank you for that. If my listeners want to hear more about you, where can they find out more, please?
Oh, that's a big compliment. Thank you.
You're
I'm on a
welcome.
quest to save Gen X, honestly. They need
Thank
us.
you.
We're the last generation that has any sense, right? Like we weren't raised on technology,
I know
but
it.
we know how to work the machines. So
Yes.
all
Yes, we
right. So
do.
I have a free 4-part video series all about, I call it Ozempic Uncovered, but it's all about GLP-1s. And you can find that at drtyna.com. It's right at the top of the page. It's DRTYNA. My Instagram's Dr. Tyna. My YouTube's Dr. Tyna. And I have a podcast called The Dr. Tyna Show, which I would love to invite you to come on. That would be so fun.
I would love to. Thank you.
Yeah, that'd be so fun. And so everything is there. And once you opt into that 4-part video series, you'll be invited in to purchase my big course. I have a big deep dive course on this geared towards health professionals, but I let the general public in because I know you guys are smart and you need the information and you need to be empowered with the education. So that's available too. And then if you get Dr. Fiona's Lovely, that's going to be the coupon code is lovely. That'll give you a better discount than you'll find at the end of that video series. So check it out. And there's like 20 hours of free education all over the internet or more with all these podcasts I've been
With
on.
the
So
podcast,
tons
yeah.
of free information out there too.
Yeah.
I've done at least 12 episodes on my pod. So yeah, have at it.
Amazing. And so people can find the course on your website, drtyna.com. Is that right?
Yeah, the free one. And if you go under courses is the big one. And in both cases, your coupon code is going to give them the best deal. It's
Ooh,
lovely.
I can't wait to take that course. So thank you for offering a coupon code for my listeners. I have a question that I ask all of my I'm about to call you a patient. All of
That's
all of
okay.
my guests.
I want to be your patient.
Bless you. I want to be yours.
We can
Um,
trade.
See, exactly. So I have a question I ask all of my guests at the end, and it goes like this. Knowing what you know now, what would you tell your younger self?
Oh gosh, I tell her to lift weights.
Practical. I love it.
No,
Yeah.
honestly, I would tell her to lift weights because it makes all the crazies go away. I have said this many times publicly. I so wish I had found this tool when I was in my 20s or even in my teens when I really started struggling with depression and all the health issues. I've had a long litany of chronic health issues, and they are all mitigated and so much more contained when I have good muscle mass and I'm consistent with my workouts. And strength training is a slow and low process. I'm not talking boot camp. I'm not talking CrossFit. I'm talking lifting heavy shit and putting it down. It really does something for that dopamine and serotonin. So, and at the end of the day, you're building an insurance policy for yourself for the long
Mhm.
run. So I wish I'd found it sooner.
I love it. This conversation is going to be very helpful for a lot of women. The information within very liberating. And so I thank you for being vulnerable. And I thank you again for coming on the show. Please come back and visit us again. I'd love to have a deeper conversation.
Yes.
And until next time, Dr. Tina Moore, thank you for joining us on the Not Your Mother's Menopause podcast.
Thank you for having me.
The information and other content provided in this show, or in any linked materials, is not intended and should not be construed as medical advice, nor is the information a substitute for professional medical expertise or treatment. We are doctors, but we aren't your doctor. Seek your doctor's opinion. If you or any other person has a medical concern, you should consult with your healthcare provider or seek other professional medical treatment. Never disregard professional medical advice or delay in seeking it because of something that you have heard in this podcast or in any linked materials. If you think you may have a medical emergency, call your doctor or emergency services immediately. The opinions and views expressed on this page and in this show have no relation to those of any academic, hospital, health practice, or other institution. Thank you.